The medical clinic chain promoted itself as a model of accessible, patient-centered health care. Modern facilities in underserved communities, evening and weekend hours for working families, multilingual staff, acceptance of all insurance plans including Medicare and Medicaid. Marketing materials emphasize the organization's mission to provide quality care regardless of ability to pay. Patient testimonials praise the convenience and attentiveness. Local news stories featured the clinics as examples of health care done right. The organization's chief executive appeared on panels discussing health care access and spoke at medical conferences about sustainable business models for serving low-income populations. Everything suggested a legitimate health care operation addressing real community needs. But in an insurance company's fraud detection unit, an analyst noticed an unusual pattern in claim submissions. The analyst reviewed medical claims using algorithms designed to identify outliers and anomalies. One particular diagnostic code appeared with extraordinary frequency in claims from a specific network of clinics. The code indicated a serious cardiovascular condition requiring extensive testing and treatment. The frequency was statistically improbable. The condition affected roughly 2% of the general population. But among patients at this clinic network, the diagnosis rate was over 30%. The clinic served a patient population with dramatically higher cardiovascular disease rates than national averages. Or something else was happening. The analyst flagged the pattern for investigation. The insurance company's Special Investigations Unit began reviewing individual claims from the clinic network. They found that many patients diagnosed with serious conditions had no prior medical history suggesting risk factors. Young, healthy individuals were being diagnosed with advanced cardiovascular disease, kidney failure, respiratory conditions, and neurological disorders. The diagnoses triggered cascading treatments, extensive diagnostic testing, specialist consultations, surgical procedures, ongoing medication regimens, follow-up monitoring. Each step generated additional insurance billing. A patient who came in for routine care might leave with diagnoses requiring tens of thousands of dollars in treatment. The insurance company contacted the FBI's Healthcare Fraud Unit. Federal investigators recognized the pattern immediately. Systematic upcoding and false diagnosis schemes had become increasingly sophisticated in healthcare fraud. Criminal organizations had discovered that medical billing offered lucrative opportunities with lower risk than traditional crimes. The FBI opened an investigation into the clinic network. Agents began by examining the organization's structure and ownership. The clinics operated as a corporate entity with facilities in 5 states. The corporation had multiple layers of subsidiary companies, management firms, and billing services that obscured ultimate ownership and control. But financial analysis traced the corporate structure back to a group of individuals with no medical training or healthcare background. The actual doctors staffing the clinics were employees with little ownership stake or decision-making authority. The business was controlled by entrepreneurs who saw healthcare as a profit opportunity rather than physicians focused on patient care. FBI investigators obtained authorization to examine medical records from patients who had been diagnosed with serious conditions at the clinics. They hired independent medical experts to review the diagnostic basis for the claimed conditions. The expert reviews were damning. In case after case, diagnoses had no supporting evidence. Patients diagnosed with cardiovascular disease had normal test results that didn't justify the diagnosis. Patients placed on expensive medication regimens showed no symptoms of the conditions being treated. Patients subjected to surgical procedures had preoperative evaluations that contradicted the need for surgery. One particularly egregious case involved a 28-year-old patient who visited a clinic for a routine physical exam. The clinic's physician diagnosed advanced kidney disease and recommended immediate specialist consultation and potential dialysis. The diagnosis was based on a single lab test that the physician claimed showed dangerous kidney function levels. But when FBI investigators obtained the actual lab results, they showed completely normal kidney function. The physician had falsified the diagnosis. The patient, frightened by the serious diagnosis, had undergone months of unnecessary specialist appointments, imaging studies, and medication before seeking a second opinion that revealed no kidney disease at all. The pattern repeated across thousands of patients. Healthy individuals were being diagnosed with fabricated or exaggerated conditions to justify extensive billing to insurance companies. The FBI expanded the investigation to examine how the fraud operated systematically across the clinic network. They discovered the organization had implemented a quota system for physicians. Doctors were required to generate minimum billing levels per patient visit. Physicians who consistently billed below targets faced pressure from management, reduced schedules, or termination. The quota system created incentive for overdiagnosis and overtreatment. Physicians who wanted to keep their jobs learned to find billable conditions even when patients were healthy. The most financially successful physicians were those who diagnosed the most serious conditions requiring the most expensive treatments. Investigators interviewed physicians who had worked at the clinics but left due to ethical concerns. Several described feeling pressured to compromise medical judgment to meet billing targets. One physician recounted being called into a meeting with administrators who showed charts comparing his billing to other physicians. He was told his numbers were too low, that he needed to be more thorough in identifying patient conditions, that the clinic couldn't sustain operations if physicians didn't generate adequate revenue. When he pushed back, explaining that his patients were generally healthy and didn't require extensive intervention, administrators suggested he might not be a good fit for the organization's practice model. He resigned rather than compromise patient care. Another physician described being given specific diagnostic codes to use more frequently. Administrators identified conditions that reimbursed at higher rates and encouraged physicians to find those conditions in their patient populations. The physician was even provided with template documentation that would justify the diagnoses in medical records. The FBI discovered the fraud extended beyond false diagnoses. The clinic network was also performing unnecessary procedures and surgeries. Patients were referred to surgical centers owned by the same corporate entity that operated the clinics. The referrals generated fees both for the surgical procedures and for the clinics that made the referrals. Federal investigators examined surgical cases where the clinic network had referred patients for procedures. Medical experts reviewed preoperative evaluations, surgical reports, and postoperative outcomes. They found numerous cases where procedures had been medically unnecessary or where risks outweighed potential benefits. One patient had undergone spinal surgery based on a clinic diagnosis of severe disc deterioration. But imaging studies reviewed by independent experts showed only minor age-appropriate changes that would typically be treated conservatively. The surgery subjected the patient to significant risks and recovery time for a condition that didn't require surgical intervention. Another patient had cardiovascular stents implanted after a clinic diagnosed dangerous arterial blockage. But the angiogram that supposedly showed blockage was normal. The stents were implanted in healthy arteries, exposing the patient to procedural risks and requiring lifelong medication to prevent clotting around unnecessary implants. The medical harm extended beyond unnecessary procedures. Patients diagnosed with fabricated conditions were placed on medication regimens that carried side effects and risks. Healthy individuals took drugs for conditions they didn't have, experiencing adverse effects without any medical benefit. Some patients developed complications from medications prescribed for non-existent diseases. The financial fraud was staggering. FBI financial analysts calculated that the clinic network had billed insurance companies, Medicare, and Medicaid for over $400 million in fraudulent claims over 6 years. The billing included false diagnoses, unnecessary procedures, services never rendered, and upcoding of routine care to appear more complex and expensive. The money flowed through the corporate structure to the beneficial owners. Profits were distributed through consulting fees, management contracts, and equipment leasing arrangements that moved money from the clinics to entities controlled by the ownership group. The structure was designed to extract maximum revenue while insulating owners from direct liability. But the FBI traced the money through the corporate maze. Financial records showed how fraudulent billing generated revenue that was systematically diverted to owners through the network of subsidiary companies. The owners lived lavishly on proceeds from healthcare fraud, luxury homes, expensive vehicles, private aviation, international travel. Federal prosecutors began building a comprehensive fraud case. The charges would include healthcare fraud, wire fraud, money laundering, and conspiracy. The prosecution would target not just individual physicians who falsified diagnoses, but the corporate leadership who designed and profited from the systematic fraud scheme. The investigation identified 23 physicians who had knowingly participated in the fraud. Some had falsified diagnoses under pressure from management. Others had performed unnecessary procedures they knew weren't medically justified. All had prioritized financial incentives over patient welfare and medical ethics. The investigation also targeted 12 corporate executives and owners who had created the fraudulent business model, implemented the quota systems, and extracted profits from fake diagnoses and unnecessary treatments. The FBI planned coordinated actions across 5 states. Arrest warrants were prepared for the physicians and executives. Search warrants targeted clinic facilities, surgical centers, corporate offices, and residences. Simultaneously, federal agencies would seize bank accounts and assets purchased with fraud proceeds. The operation executed at dawn on a Thursday. FBI agents arrested executives at their homes and physicians at clinic facilities before patient hours began. The arrests were coordinated to prevent suspects from destroying evidence or coordinating responses. At each clinic location, FBI agents posted notices informing patients that the facilities were under federal investigation for healthcare fraud. Patients with upcoming appointments were advised to seek care elsewhere. Patients who believed they had received unnecessary treatment were provided with contact information for victim services. The impact on patients was immediate and chaotic. Thousands of individuals who had been receiving care at the clinics suddenly needed to find new providers. Patients on medication regimens needed new physicians to evaluate whether the medications were actually necessary. Patients who had undergone procedures needed independent medical evaluations to assess potential harm. Federal prosecutors unsealed indictments detailing the scope of the fraud conspiracy. The indictments outlined how the clinic network had systematically defrauded insurance programs, performed unnecessary procedures, and endangered patient health for profit. The Department of Justice held a press conference. The Assistant Attorney General described the case as one of the largest healthcare fraud prosecutions in recent years, emphasizing that the fraud had not only stolen money from insurance programs, but had actively harmed patients through unnecessary interventions. The medical community responded with shock and concern. How had so many physicians participated in systematic fraud? How had the scheme operated for years without detection? What failures in oversight had allowed fraudulent clinics to proliferate? Medical licensing boards in all 5 states opened investigations into the physicians involved. Professional medical organizations issued statements condemning the fraud and emphasizing that the vast majority of physicians practiced ethically. But the case raised uncomfortable questions about how financial pressures in healthcare could corrupt medical judgment. The trials began 18 months after arrests. Prosecutors had overwhelming evidence. Patient records showing false diagnoses, expert medical testimony contradicting the clinic's diagnostic claims, financial records proving the profit motive, and testimony from physicians who described the pressure to generate billing. Several physicians agreed to plead guilty and cooperate with prosecution of the corporate leadership. Their testimony described the internal workings of the fraud scheme, how quotas were enforced, how administrators coached physicians on billing optimization, how concerns about patient welfare were dismissed as interfering with business operations. The trial of the corporate leadership lasted 3 months. Prosecutors presented evidence that executives had knowingly designed a business model based on fraudulent billing. They showed emails where executives discussed maximizing revenue through aggressive diagnosis coding. They presented financial analyses showing that the business model depended on diagnostic rates that were medically implausible. The defense argued that the executives were business people, not doctors, and had relied on medical staff to make appropriate clinical decisions. They claimed any fraud was committed by individual physicians acting independently, not as part of a corporate conspiracy. But the evidence contradicted that defense. The quota systems, the billing targets, the pressure on physicians, the profit distributions tied to fraudulent billing, all demonstrated that the corporate leadership had orchestrated the fraud scheme and knowingly profited from it. The jury convicted the lead executives on all major counts. The physician defendants either pleaded guilty or were convicted at trial. Sentencing reflected the severity of the crimes and the harm to patients. The corporate chief executive received 35 years in federal prison. Other executives received sentences ranging from 12 to 25 years. Physicians who had knowingly falsified diagnoses received sentences between 8 and 15 years. Asset forfeiture orders seized over $200 million in cash, property, and business assets. But the convictions didn't undo the harm to patients. Thousands of individuals had undergone unnecessary procedures, taken medications they didn't need, and suffered psychological trauma from being told they had serious medical conditions that were fabricated. The federal government established a victim assistance program to help affected patients obtain independent medical evaluations, correct medical records that contained false diagnoses, and access compensation for medical harm. The program coordinated with state medical boards and insurance companies to ensure patients could get appropriate care. The healthcare fraud case triggered regulatory reforms. Medicare and Medicaid implemented enhanced screening for new healthcare providers, requiring more extensive background checks on ownership and financial structures. Insurance companies strengthened their fraud detection systems, focusing on diagnostic coding patterns that deviated from statistical norms. Medical licensing boards established new requirements for physicians to report employer pressure to provide inappropriate care. Professional medical organizations created confidential reporting systems for physicians facing ethical conflicts between patient welfare and business demands. But implementation of reforms faced challenges. Enhanced screening added bureaucratic hurdles for legitimate healthcare providers trying to serve underserved communities. Fraud detection algorithms sometimes flagged legitimate practice variations as suspicious. Reporting systems for physician concerns required protections against retaliation that were difficult to enforce. The tension between preventing fraud and enabling health care access remained difficult to balance. Overly restrictive oversight could drive healthcare providers away from low-income communities that desperately needed services. But insufficient oversight enabled fraudsters to exploit vulnerable populations. The FBI maintained investigations into suspicious healthcare billing patterns in multiple regions. The clinic network fraud wasn't an isolated case. Similar schemes operated in different states with different corporate structures, but the same basic model. Diagnose fabricated conditions, perform unnecessary procedures, bill insurance programs, extract profits. 5 years after the initial arrests, federal investigators estimated that healthcare fraud cost government insurance programs and private insurers over $60 billion annually. The fraud took many forms: phantom billing for services that were rendered, kickback schemes between providers and suppliers, prescription drug fraud. But systematic false diagnosis schemes represented a growing and particularly harmful category. The harm wasn't just financial. Patients subjected to unnecessary medical intervention suffered real physical and psychological damage. Unnecessary surgeries carried procedural risks. Unnecessary medications caused side effects. False diagnoses created anxiety and stress. The fraud violated the fundamental trust between patients and healthcare providers. The FBI's investigation had dismantled one fraudulent clinic network and prosecuted its operators. But investigators knew that healthcare fraud would continue evolving as criminals adapted to enforcement efforts and found new methods to exploit the complexity of medical billing systems. The work of detecting and prosecuting healthcare fraud required ongoing vigilance from law enforcement, insurance companies, medical professionals, and patients themselves. It required sophisticated data analysis to identify suspicious patterns. It required medical expertise to evaluate whether diagnoses and treatments were justified. It required financial investigation to trace money through complex corporate structures. And sometimes it required an insurance analyst noticing that one diagnostic code appeared far too frequently in claims from a particular network of clinics. The clinic facilities stood empty for months after the arrests. Eventually, some were purchased by legitimate healthcare organizations that reopened them to serve the communities that had lost access to care. The new operators emphasized transparency, patient advocacy, and medical ethics. But in those same communities, patients remained wary. They had trusted a healthcare system that betrayed them. They had followed medical advice that was designed to generate billing rather than improve health. Rebuilding that trust would take years of demonstrated integrity from new providers. One patient, speaking at a sentencing hearing, captured the profound violation. "I trusted my doctor when he told me I was sick. I believed him when he said I needed surgery. I went through months of fear, pain, and recovery for a condition I never had. He didn't care about my health. He cared about billing codes and quotas. That's not medicine. That's criminal exploitation of people when they're most vulnerable." That statement resonated beyond the courtroom. Healthcare fraud wasn't just white-collar crime. It was a violation of the sacred trust that patients place in medical professionals when they seek help. It was exploitation of vulnerability for profit. It was harm disguised as healing. The FBI's investigation had exposed that exploitation and held the perpetrators accountable. But the case also revealed how easily healthcare systems could be corrupted when profit motives overwhelmed ethical obligations, when business metrics replaced medical judgment, when billing targets mattered more than patient outcomes. Preventing future fraud required more than law enforcement. It required a healthcare culture that valued integrity over revenue, that protected physicians who prioritized patient welfare over billing optimization, that treated medicine as a healing profession rather than a profit extraction mechanism. The convictions sent a message that healthcare fraud would be prosecuted aggressively. But the deeper challenge remained: creating healthcare systems where doing the right thing for patients was also the financially sustainable thing for providers, where serving communities didn't require compromising medical ethics to meet business targets. Until that alignment existed, healthcare fraud would continue. Different schemes, different corporate structures, different methods, but the same fundamental corruption, using medicine to steal money rather than to heal people, until someone notices the pattern in the billing data, until someone asks why so many healthy patients are being diagnosed with serious diseases, until someone contacts the FBI.